Welcome dear students, in continuation to the complications of otitis media. In this video, let us look into two important complications, one being petrositis and the second being facial paralysis. Let's begin with petrositis. What is petrositis? Inflammation of petrous bone, petrous part of temporal bone. Now we all know that temporal bone has four parts: mastoid, squamous part, tympanic part and the petrous part. Inflammation of the petrous part is called as petrositis. So the infection is spreading from the middle ear and mastoid into the petrous part of temporal bone, and that is called as petrositis. Now it can follow acute mastoiditis or latent mastoiditis, or even it can occur as a direct complication of chronic suppurative otitis media. Repeat. It can follow coalescent mastoiditis or latent mastoiditis, or it may occur as a direct complication of suppurative otitis media, that is your petrositis. Petrous part of temporal bone is inflamed. This is preceded either by acute mastoiditis or latent mastoiditis or even suppurative otitis media. Now just like how the mastoid bone could be sclerotic, it could be diploic, depending upon the pneumatization, right? Even the petrous bone can be any of the three types. It could be pneumatized with good air cells extending, or it could be diploic where there is marrow space, or it could be sclerotic, no air cells, no marrow space. Pneumatization of the petrous apex occurs in very few people, in about 1/3 of the population, and that pneumatization, the air cells extend either from the mastoid to the petrous apex or from the middle ear to the petrous apex. Now, how is the infection spreading from the mastoid or middle ear into the petrous apex is important. There are two routes that have been understood. One is a posterior-superior tract. This starts from the mastoid, and from the posterior aspect it runs up behind or above the bony labyrinth, and it reaches the petrous apex. Now some of the cells, they even arch the superior semicircular canal also. So this is one route, posterior-superior. It begins in the mastoid. And the second route is opposite to posterior-superior, that is antero-inferior. What's happening in the antero-inferior route? This starts in the hypotympanum near the eustachian tube. What is present in the anterior side? It is the eustachian tube. So it begins in the eustachian tube and it runs around the cochlea and reaches the petrous apex. This is the second route. So are the two routes clear to you, how the infection is spreading from the middle ear into the petrous bone? Now it runs along these cell tracts and it reaches the petrous apex. Now the pathology that is occurring, it's very similar to what is happening in mastoiditis. The infective cells reach there, and then there is the exudate that is formed. All the purulent exudate gets accumulated, and finally it leads to abscess formation. Epidural abscess is formed in the petrous apex. It ends with the formation of epidural abscess in petrous apex. Now let us look into the clinical features. What is very important is, while taking this route and reaching the what is very important is the route of the infection while traversing from the middle ear into the petrous apex, what all is it involving and what is the result of that involvement. Altogether, this is called as a very important syndrome, that is Gradenigo syndrome. Gradenigo syndrome. another eponym that is seen in ear. So this Gradenigo syndrome is a classical presentation. It consists of a triad. What are the three features in the triad? First, there is external rectus palsy. Why is there external rectus palsy? This extraauricular muscle, external rectus, is supplied by, lateral rectus is supplied by 6th cranial nerve. When the 6th cranial nerve is involved, it leads to external rectus muscle palsy, and that will lead, it will present as diplopia or double vision. This is number 1. Presents as diplopia. The next feature is there is deep-seated retroorbital pain or deep-seated ear pain. Why is this occurring? Because these structures are supplied by the 5th nerve, and the 5th cranial nerve, when involved in this infective process, will lead to this presentation. And the third part of the triad is persistent ear discharge. Persistent ear discharge, I need not explain, it is self-explanatory. In the situation of mastoiditis or middle ear infection, there will be ear discharge, and when it has complicated, gone so far up to the Petrous apex, it will become persistent. So these are the three features that are seen in Gradenigo syndrome. Please remember that the 5th and the 6th cranial nerves are involved, and they cause 2 of the manifestations, and persistent ear discharge is the obvious 3rd manifestation. Now, with the advent of antibiotics, with the modern treatment, it's rare that we see all the 3 in a single patient. It's quite uncommon to see the complete triad and label someone as Gradenigo syndrome. Persistent ear discharge will be there with or without deep-seated ear pain. That itself points out towards petrositis. And of course, the constitutional symptoms such as fever, headache, neck rigidity, all of them will be present. And when you have a diagnosis of petrositis, even if all the 3 are not present, with the advent of antibiotics, it is uncommon these days to see the complete triad in a single patient. So just when there is persistent ear discharge, even if the deep-seated retroorbital pain or ear pain is present or not present, we can consider the diagnosis of petrositis. If an adequate surgery has already been performed and still these symptoms are present, it generally points towards petrositis. And of course, constitutional symptoms such as fever, headache, vomiting, all of them will be present. And depending upon the structures involved, sometimes the facial nerve can get involved, and that leads to facial paralysis. Sometimes other structures, inner ear structures can get involved, leading to recurrent attacks of vertigo. All these are possible. So how do we accurately diagnose? By going for radiological investigations. CT and MRI are required. First, we go for a CT scan of temporal bone. And in the CT of temporal bone, you will see that the bony details of the Petrous apex and the air cells, all of them are seen, and you can see the extent of destruction, the extent of the disease process. Next, we go for an MRI. Why is MRI required? MRI will help you to differentiate between fluid or pus that is seen in petrositis versus the normal fatty or marrow containing spaces that are present in the diploic cells. For that, MRI is required. Then coming to the treatment of petrositis, mastoidectomy is the treatment, either cortical mastoidectomy or modified radical or radical mastoidectomy. Usually you see that by then already these surgeries have been performed, and in case it has not been performed already, they have to be done immediately. Mastoidectomy. And the fistulous tract that is present, that is carrying the infection, you have to identify that and curate all that infected material and enlarge the path so that there is free drainage. Now you know that the posterior superior tract begins in the mastoid and the anterior inferior tract begins in the eustachian tube. So accordingly you have to search for and do the necessary debridement and treatment. Another point that you have to remember is, if it is an anteroinferior tract that is beginning from the opening of eustachian tube, a radical mastoidectomy is required. If it is the anteroinferior tract, it mandates a radical mastoidectomy. So apart from that, what else is important? Very important, in fact, it is adequate IV antibiotic therapy. Before and after the surgery also, antibiotics are required. Adequate antibiotics in high doses, IV doses, they have to be given for about 4 to 5 days. Even if the symptoms subside, 5 complete days course of antibiotics is required. Now, if the antibiotics are effective and they're working well, sometimes you do not even need the surgery. Just with antibiotics alone, we can cure this condition. So this is about Petrositis. It's a pretty simple condition, inflammation of the Petrous apex. And in clinical features, all you have to remember is Gradenigo syndrome. All the constitutional symptoms like fever, ear pain and all that you will anyhow remember. Please remember Gradenigo syndrome seen in Petrositis. What are the 3 symptoms in the triad of Gradenigo? Number 1, retroorbital pain or deep-seated ear pain because of the 5th nerve involvement. Then diplopia or double vision because of the 6th nerve involvement, which is causing lateral rectus muscle palsy. And the third is persistent ear discharge. All these 3 together are seen in all these 3 together are seen in Gradenigo syndrome as a part of Petrositis. Even if all 3 are not seen in practical clinical purposes, we can still give a diagnosis of Petrositis because with the advent of antibiotics, it's rare that you see all the 3. But for exam point of view, Gradenigo syndrome is quite important. And CT and MRI will give you a clear diagnosis of Petrositis, and surgical treatment is required along with a strong, good, high dose of IV antibiotics. Now let us move on to the next complication after Petrositis. Now until now we have studied mastoiditis, we have studied Petrositis, and now let us look into facial paralysis. So facial paralysis can occur as a complication of ASOM as well as CSOM. Now you know that the facial nerve is closely traversing in the middle ear, so any infection in the middle ear can lead to facial nerve infection and eventually facial paralysis. Let us see it in detail separately, what's happening in ASOM and what's happening in CSOM. If it is a case of acute otitis media, see, normally the facial nerve is well protected, it's in a bony canal. Except when there are some congenital dehiscence, as we have discussed in bony erosions and preformed pathways, right? If there is a congenital dehiscence of the fallopian canal and the facial nerve is exposed just under the mucosa of middle ear, it is of course vulnerable to all the infective and inflammatory processes that are going on in the middle ear. And that's when it becomes susceptible. Now this nerve, either the infection can spread up to the epineurium or to the perineurium depending upon the extent. So if the acute otitis, so if ASOM is adequately controlled with systemic antibiotics, then even if the facial nerve is partially involved, it can fully recover if it is acute otitis media that has caused it and if it has been adequately controlled. Sometimes, of course, surgical treatment like myringotomy or cortical mastoidectomy may be required. But otherwise, in ASOM, understand that it is not very serious and a full recovery is possible. So what you have to remember here, one is, if there is a congenital or any other reason that is leading to bony dehiscence, this makes the facial nerve susceptible. In second, recovery is possible. Now let us see what is happening in CSOM. Now in CSOM, facial paralysis can occur mostly because of a cholesteatoma. Cholesteatoma destroys all the surrounding structures. It destroys the bony canal first. Now in ASOM usually occurs if there is a pre-existing bony dehiscence. But here, there also without dehiscence, it's possible that there occurs hyperemic decalcification and the facial nerve is involved. But usually it occurs if there is an pre-existing bony dehiscence. But CSOM, even when the bony canal is intact, cholesteatoma can destroy the bony canal and expose the facial nerve. It will first destroy the bone and then it will exert pressure on the nerve, and there is edema, there is all that inflammatory exudate and biodegradable repeat, and enzymes are also present. All this will further damage the nerve. It's a very gradual process, it's not something acute. But treatment has to be done very urgently because it's the facial nerve and we cannot take chances with it. Urgent exploration has to be done of the middle ear and mastoid, and you have to treat it very, very quickly. So this is about cholesteatoma, and even granulation tissue, penetrating granulation tissue can also cause something similar. You have to inspect the facial canal right from the geniculate ganglion to the stylomastoid foramen. If there is cholesteatoma or granulation tissue that is invading the bony canal, you have to debride that entire area of involvement. But please remember, if it is already invaded into the nerve, then it is better to leave that like that at that point, because when you try to remove, we do not know how deeply it has penetrated the nerve, and sometimes you might end up destroying the nerve more than what is already destroyed. So at that point it is better to leave it like that, go for medical treatment, and later after fibrosis has occurred, then you can go for a resurgery and remove the infected part and go for resection and grafting of the nerve. If at all the nerve sheath is completely invaded, at that time this is the approach that has to be taken. After the infection subsides, after it is controlled and fibrosis has occurred, then go for a revision surgery, resect and graft the nerve. If it has not gone up to the nerve sheath, only the bony canal is destroyed, just remove the area that has been invaded by the cholesteatoma. This is about CSOM and how it's causing facial paralysis. So facial paralysis is an important complication, but it's very simple to understand and there is nothing much to learn about it here. With this, we complete another 2 complications. There is one more in intratemporal list, and that is labyrinthitis. Let's look at labyrinthitis in the next video. I hope petrositis and facial paralysis are clear to all of you. Thank you very much.